A very good morning to all. Today's topic is malignant tumors. Neoplasm. Neoplasm is an abnormal growth of tissue, also known as a tumor, meaning new formation. The definition: a tumor is an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of the normal tissues and persists in the same excessive manner after cessation of the stimuli which evoke the change. Tumor can be classified as benign tumor and malignant tumor. Benign tumors, they are non-malignant, non-cancerous tumor. They are usually localized and does not spread to other parts of the body. They are typically slow growing. Most benign tumors respond well to treatment and they often have well-defined borders, so surgical removal can be an effective treatment. However, if left untreated, some benign tumors can grow large and lead to serious disease because of their size. Benign tumors can also mimic malignant tumors and so for this reason are sometimes treated. Benign tumors can be serious if they press on vital structures such as blood vessels or nerves. Sometimes they require treatment and other times they do not. Malignant tumors, they are cancerous growths, usually fast growing. They are often resistant to treatment, may spread to other parts of the body, and they sometimes recur after they were removed. A very important question that comes as a short note or can be asked in Viva is the difference between benign and malignant tumors. So, we should have a quick look on the differences between benign and malignant tumors. Starts with cell characteristics. Benign, well differentiated cells that resemble normal cells of the tissue from which the tumor originated. Malignant cells are undifferentiated and often bear little resemblance to the normal cells of the tissue from which they arose. Mode of growth: benign tumors grows by expansion and does not infiltrate the surrounding tissues, usually encapsulated. Malignant tumors grows at the periphery and sends out processes that infiltrate and destroy the surrounding tissues. Rate of growth: benign rate of growth is usually slow. Malignant rate of growth is variable and depends on level of differentiation. The more anaplastic the tumor, the faster is its growth. Metastasis: benign tumors does not spread by metastasis. Malignant tumors, yes they do, gains access to the blood and lymphatic channels and metastasizes to other areas of the body. General effects: benign is usually a localized phenomenon that does not cause generalized effects unless its location interferes with vital functions. Malignant often causes generalized effects such as anemia, weakness, and weight loss. Tissue destruction: benign does not usually cause tissue damage unless its location interferes with blood flow. Malignant often causes extensive tissue damage as the tumor outgrows its blood supply or encroaches on blood flow to the area, may also produce substances that cause cell damage. So these were some of the differences between benign and malignant tumors and is very important. Now, the nomenclature. Benign tumors, the benign tumors, OMA, benign neoplasms, classified as mesenchymal tumors and epithelial tumor. Mesenchymal tumors, example chondroma, fibroma, osteoma. Epithelial tumors, adenoma, papilloma, papillary, cyst adenoma. For malignant tumors can be sarcomas, carcinomas. Sarcomas, chondrosarcoma, fibrosarcoma, osteosarcoma. Carcinomas, adenosarcoma, squamous cell carcinoma, undifferentiated carcinoma. We'll start with squamous cell carcinoma. Makes up 95% of all oral cavity cancers. They are classified based on macroscopic or microscopic features. Can be classified as infiltrative, deeper layers of the oral cavity; exophytic, grows outwards from the surface of the oral cavity; verrucous, wart-like appearance; ulcerated, appears as an open sore; flat, appears as an abnormal area in the lining of the oral cavity. Most cancers of the oral cavity are classical or conventional squamous cell carcinoma. This type of squamous cell carcinoma starts in the squamous epithelium that lines the oral cavity and occurs most often on the lower lip, tongue, and the floor of the mouth. The microscopic features of classical squamous cell carcinoma includes epithelial pearls Epithelial pearls are circular layers of squamous cells around a collection of keratin in the center. Spread of cancer into deeper layers of the oral cavity. The cancer starts in the squamous cells of the epithelium and invades the deeper layers of the oral cavity. Variants of squamous cell carcinoma, verrucous carcinoma, make up less than 5% of the oral cavity. As I already told, wart-like appearance and develop mostly on the gingiva, buccal mucosa and larynx. They are of low grade, slow growing and rarely spread. Basaloid squamous cell carcinoma, this is a rare but aggressive subtype of squamous cell carcinoma. Then papillary squamous cell carcinoma, a rare subtype of squamous cell carcinoma that grows outward from the surface of the epithelium, that is, it is exophytic. Spindle cell carcinoma, this is an aggressive rare variant of squamous cell carcinoma. These tumors contain a mixture of conventional squamous cell carcinoma and spindle cells that resemble a sarcoma, also known as sarcomatoid carcinoma, pseudosarcoma, carcinosarcoma, pleomorphic carcinoma, metaplastic carcinoma, collision tumor, and Lane tumor. Acantholytic squamous cell carcinoma, it is a rare variant of squamous cell carcinoma in which the connections between the malignant squamous cells break down. This results in microscopic spaces in the tumor tissue which appear like glands or vascular spaces. Adenosquamous carcinoma, this is a very rare aggressive type of squamous cell carcinoma. It looks like classical squamous cell carcinoma but also has a mucus containing gland cells. Lymphoepithelial carcinoma, this is a rare subtype of a squamous cell carcinoma. The microscopic appearance is similar to undifferentiated nasopharyngeal carcinoma. It is also called undifferentiated carcinoma. Real malignant tumors, salivary gland carcinomas, melanomas. Melanomas rarely develops in the oral cavity. It occurs most commonly on the roof of the mouth. Odontogenic tumors, origin unique to jaws, developmental cellular debris from forming teeth. Epithelial or mesenchymal. Epithelial originates from the remnants of Hertwig's epithelial root sheath, that are cell rests of molasses, and remnants of dental lamina, that are cell rests of serae, and reduced enamel epithelium. Odontogenic tumors, classification from odontogenic epithelium only, mixed epithelium and mesenchyme, odontogenic mesenchyme only. Location can be central or peripheral. Peripheral are rare. Ameloblastic fibroma, ameloblastic fibroodontoma, ameloblastic fibrosarcoma, odontoma, odontoameloblastoma, odontogenic fibroma, odontogenic myxoma, cementoblastoma, central cemento-ossifying fibroma, peripheral odontogenic ossifying fibroma. Odontogenic tumors. The general considerations: non-descriptive jaw swelling, usually asymptomatic, well-defined radiolucent or mixed radiolucency and radioopacity. Some odontomas are opaque only. Unilocular or multilocular radiolucency can be well-defined or corticated. Often it expands the bone, may resorb and displace the teeth. Treatment and prognosis depend on specific tumor type, that is enucleation and resection. Odontogenic epithelial tumors, the very important tumor is ameloblastoma, also known as adamantinoma. Types: conventional solid ameloblastoma, cystogenic ameloblastoma, desmoblastic ameloblastoma, peripheral ameloblastoma, also malignant ameloblastoma, and ameloblastic carcinoma. It is very important, can come as a long note or a short note. Calcifying epithelial odontogenic tumor, CEOT, Pindberg's tumor. Squamous odontogenic tumor and clear cell odontogenic tumor. Ameloblastoma, most common odontogenic tumor. It is benign but locally invasive, clinically and histologically similar to basal cell carcinoma, occurs in 5th and 4th decades of life, occasionally arise from dentigerous cysts. Subtypes can be multicystic, unicystic, and peripheral. Multicystic accounts for 86%. Radiographic findings: classic multilocular radiolucency of posterior mandible, well circumscribed, soap bubble appearance. Unilocular, often confused with odontogenic cyst. Root resorption will be there associated with melanin. This is a radiographic picture of ameloblastoma. This is the histological variants of ameloblastoma. There are so many different types: plexiform, acanthomatous, follicular, basal cell. Treatment of ameloblastoma. According to growth characteristics and type: unicystic complete removal, peripheral osteotomies if extension through cyst wall, classic infiltrative, that is aggressive, mandibular, adequate normal bore around margins of resection, maxillary, more aggressive surgery, 1.5 centimeter margins, ameloblastic carcinoma, radical surgical resection, neck dissection. For doing the surgical management of ameloblastoma, there can be enucleation, Sepo procedure, resection. Resection constitutes of marginal resection, segmental resection, en bloc resection, and also hemimandibulectomy with condyle, hemimandibulectomy without condyle. If any tumor involves in the maxilla, we have to do a partial maxillectomy or a total maxillectomy. For that, we have to give a Weber percussion incision till the lateral canthus, and if there is an extension, it is known as Diefenbach incision. Calcifying epithelial odontogenic tumor, also known as Finberg's tumor, aggressive tumor of epithelial derivation, impacted tooth, it occurs in mandibular body or ramus region. The chief sign is expansion of the cortical plates, pain not normally a complaint. Radiographic findings: expanded cortices in all dimensions, radiolucency, that is poorly defined, non-corticated borders, unilocular, multilocular or moth-eaten, driven snow appearance from multiple radio-opaque foci, root divergence, resorption will be there. There will be presence of impacted tooth. This is a radiographic picture of Finberg's tumor, then the surgical resection and the post-op after removal. CEOT, Finberg's tumor. As I already told, there can be a radioopacity and the presence of impacted tooth. This is the histological slide. Islands of eosinophilic epithelial cells. Cells infiltrate the bony trabeculate. Nuclear hyperchromatism and pleomorphism. Semoma-like calcifications, Lees gangrens. Here you can see the Lees gangrens. This is the pathognomonic histological feature of calcifying epithelial odontogenic tumor. Treatment of calcifying epithelial odontogenic tumor includes, as it behaves like ameloblastoma but has got smaller recurrence rate, en bloc resection, hemimandibulectomy, partial maxillectomy is suggested. Adenomatoid odontogenic tumor or AOT associated with the crown of an impacted inferior tooth. There will be painless expansion. Radiographic findings are well-defined expansile radiolucency, root divergence will be there, calcified flex. Histology includes thick fibrous capsule, clusters of spindle cells, columnar cells, rosettes, ductal throughout, and the treatment is enucleation. Recurrence is rare for AOT. This is the radiographic picture of AOT, as you can see in the maxilla, and histological picture. This is the surgical removal of adenomatoid odontogenic tumor. This is the gross thick capsule. This is the histological slide where you can see like duct-like spaces. Squamous odontogenic tumor, hematomatous proliferation, maxillary incisor, canine and mandibular molars are involved. Tooth mobility is the common complaint. Radiology includes triangular localized radiolucency between contiguous teeth. Histology includes oval nest of squamous epithelium in mature collagen stroma. Treatment is extraction of the involved tooth and thorough curettage. If it occurs in maxilla, more extensive resection should be there. Recurrence, treat with aggressive resection if there is recurrence. This is the radiographic picture and the histological picture of squamous odontogenic tumor. Mesenchymal odontogenic tumors includes odontogenic myxoma and cementoblastoma. Mixed odontogenic tumors, examples ameloblastic fibroma, ameloblastic fibrodentinoma, ameloblastic fibrodontoma, odontoma. Both epithelial and mesenchymal cells are involved. It mimics differentiation of developing tooth. The treatment is enucleation, thorocurettage with extraction of impacted tooth. Ameloblastic fibrosarcomas, they are malignant. Treat with aggressive or block resection. Thank you. Stay safe. Stay home.